Welcome to the section on adrenal function. Just a little overview of the adrenal gland. You can see the kidneys in the right top part of your screen here, and they're little pyramid-shaped organs that sit on top of the kidneys. The glands, actually, not organs. They produce steroid hormones and neuropeptides, which are essential for life. Things such as blood pressure and electrolyte balance are really controlled by these glands. If you look in the bottom right-hand part of your screen, you'll see there are several portions to the adrenal gland. We've got the different zones, G, F, and R. The zones are in the cortex, and there's also the medulla. The majority of the adrenal gland is the cortex, and only 10% of it is the medulla. So let's look at each of these zones and what they do. Let's look at the adrenal cortex and the steroidogenesis that occurs in this area first. All of the adrenal steroids are derived from the sequential enzymatic conversion of cholesterol. So everyone thinks of cholesterol as such a bad guy, but really he's very important in the making of all these hormones, especially steroids. Cortisol, estradiol, aldosterone, and androstenedione are synthesized and secreted by the adrenal cortex. Only free cholesterol can enter the steroidogenic pathways in response to the adrenal corticotropic hormone. We talked about the adrenal corticotropic hormone in our pituitary chapter, and this is released from the anterior pituitary to cause the adrenals to release these items. The conversion of that cholesterol to pregnenolone is a rate-limiting step. If that step does not occur, if the cholesterol does not turn into pregnenolone, it will stop the steroid synthesis. So that is a very important piece. The evaluation of adrenal function requires measuring relevant adrenal hormones, metabolites, and regulatory secretagogues. So there's all different things that we need to look at when we're looking at possible dysfunction of the adrenal gland. This is one of my favorite pictures. It does a really good job of depicting some of the things that the adrenal gland does. In this picture, we see the adrenal gland sitting on top of the kidney here. And let's start with our blood pressure falling. So we're going to go down to the bottom of the picture. And when your blood pressure falls, the kidney actually picks up that fall in blood pressure. It secretes renin, which starts the angiotensinogen-angiotensin cascade here. Renin causes a conversion of angiotensinogen to angiotensin 1 to angiotensin 2 with the help of angiotensin converting enzyme. This on its own raises the blood pressure a little bit, but it also tells the kidney to release aldosterone, which tells the kidney to retain more salt in the body system, which will make the blood pressure rise. Let's look at some of the diseases of the adrenal glands. When we refer to them having diseases, we use the word aldosteronism. Aldosterone is a steroid that increases renal tubular retention of sodium and increases excretion of potassium. It is a major player in sodium balance. So we can have hyperaldosteronism and hypoaldosteronism. Let's look at each one. Hyperaldosteronism, also known as Conn's disease. We can have two pieces to this. It can be a primary hyperaldosteronism or a secondary hypoaldosteronism. They each have different causes. The primary hyperaldosteronism is uncommon and usually due to some type of an aldosterone secreting tumor. So you have a tumor in your body, it just starts secreting like crazy. Secondary hyperaldosteronism, on the other hand, is due to an excess production of renin and can be caused by the narrowing of renal arteries, malignant hypertension, or a renin-secreting renal tumor. So the renin is causing the excess angiotensinogen cascade, which is then telling the adrenal gland to secrete the excess aldosterone. So Conn's is hyperaldosteronism. On the other hand, we can have hypoaldosteronism. This is known as Addison's disease. And this is usually caused by the autoimmune destruction of the adrenal glands. With these patients, we see weakness, fatigue, anorexia, nausea, diarrhea, abdominal pain, weight loss. And what happens is the pituitary starts releasing tons and tons of adrenal corticotropic hormone to try and get the adrenal gland to release more steroids. And what happens is it tries and tries and tries, but nothing is released. Okay, we don't get the a release of aldosterone like maybe we would if the ACTH or if it worked. So ACTH tries and tries and tries and tries and tries and tries and tries to the point that the levels get up around 200 picograms per mil, but yet nothing happens. So we see those ACTH levels quite high. We also see a low cortisol because the adrenal gland's just not working. There's been some destruction there. We do treat this with steroids. Both primary and secondary hypoadrenalism cause low cortisol weakness and possible low blood sugars. Some of the tests that we can do to diagnose if somebody has adrenalism is urinary potassium excretion. We can look at that and see how much they are excreting. That can give an indication and lead us in that direction. We can do an upright PA-PRA ratio, a catapril suppression, an 18-hydroxycorticosterone level, adrenal imaging, and adrenal vein sampling. Notice I didn't go into detail on these. We could spend a whole nother lecture on those alone. Just be familiar with a few of the things that we can do for the testing. Here's an example of hypocortisolism. This can be caused by an overproduction of corticotropic releasing hormone from the hypothalamus or an overproduction of adrenal corticotropic hormone from the anterior pituitary. There's adrenal glucocorticoid secretion and exogenous intake that can cause this as well. So if you're taking some medication and it can cause too much of this cortisol to occur. So usually we call this Cushing's disease if you have excess cortisol, and it creates a certain look in a patient. This happens to be a child in the upper right-hand corner. And some of the symptoms include that moon face that you see. It's got a very round face. It is full, it's red. Another common thing that happens is fat collects between the shoulders. We kind of call that a buffalo hump. There's obesity, which presents itself in an extended abdomen with thin arms and legs. So what causes this Cushing syndrome? Cushing syndrome occurs when the body's tissues are exposed to high levels of cortisol for a long period of time. Many people develop Cushing syndrome because they take glucocorticoids or steroid hormones that are chemically similar to the naturally produced cortisol. Some examples might be prednisone for asthma, rheumatoid arthritis, lupus, or other inflammatory diseases. Glucocorticoids are also used to suppress the immune system after transplantation to keep the body from rejecting new organs or tissue. Now, I look at an example that I can think of that somebody that had this look was my father-in-law who was on steroids at the last stages of cancer. And that caused him to have that round face. He was almost unrecognizable, actually. Other people develop Cushing syndrome because their bodies just produce too much cortisol. Normally, the production of cortisol follows a precise chain of events. First, the hypothalamus, a part of the brain that we talked about, releases corticotropic releasing hormone. This tells the pituitary to secrete adrenocorticotropic hormone, which stimulates the adrenal glands. When the adrenals, which are located just above the kidneys, receive the adrenocorticotropic hormone, they release cortisol into the bloodstream. It has several effects. Cortisol performs vital tasks in the body, including helping maintain blood pressure and cardiovascular function. It can reduce inflammatory response. It can balance the effects of insulin, which breaks down glucose for energy. And it regulates the metabolism of protein, carbohydrates, and fats. You might hear on the news sometimes and things that cortisol is the enemy. Cortisol is the hormone that makes you fat, that gives you the large abdomen. Well, in somewhat this is true. People that eat too many carbohydrates, for example, too much sugar, have high stress in their lives, it can cause an overproduction of cortisol, which can create some of these looks in people. So what are some of the steps we do to diagnose this? Well, we can do a urine cortisol and look for cortisol levels there. We can do a random plasma cortisol. But the best thing to do is a AM and a PM cortisol. If you do this and somebody has Cushing's disease, the AM levels and PM levels will be very similar. That means diurnal rhythm is lost. The late night values remain almost as high as they were in the morning. Our bodies have high cortisol in the morning because it tells us to go out and eat, to use energy, things like that in the morning. So that's what naturally is supposed to happen. Well, if those remain high at night, that's when we kind of run into a problem. So the diurnal rhythm is lost. Level remains high all day. We can also determine the loss of normal cortisol suppression by dexamethasone. And we can treat this with surgery, radiation, or other medications to suppress the adrenal cortisol production. Here's a nice chart. I've included it in your study guide as well to be familiar with what these levels are in these different diseases. You want to know the aldosterone, cortisol, and renin level in each of these: Conn syndrome, hyperaldosteronism, secondary, Cushing syndrome, and Addison's disease. Be familiar with those, especially the aldosterone and cortisol. Some other things that can happen, we can have an excess of some other steroids. The androgen excess is something that can occur. In boys, we can see penile enlargement, hair growth, precocious puberty, ambiguous genitalia, hirsutism, acne, clitoromegaly, short stature, precocious puberty. In women, we can see infertility, hirsutism, which is excess hair, acne, male pattern baldness, menstrual irregularities, and virility. In men, we see infertility, which can have a decrease in also muscle mass, hair growth, testes size, and a lowering in testosterone production. We also see a spermatogenesis loss. Diagnosis, we see high levels of DHEA with a S and DHEA in testosterone. We can surgically remove the tumors as well. Another thing we can see is congenital adrenal hyperplasia. With this, we see a sharp increase of a 17-hydroxyprogesterone, which it can be secreted from the adrenal glands. Shortly after birth, we notice the ambiguous genitalia, as you see in this picture. We also see hyponatremia, which is low sodium, hyperkalemia, which is high potassium, and a low blood pressure, known as hypotension. All right, the next portion of the adrenal glands is the adrenal medulla. This is about 10% of the entire adrenal gland. These secrete catecholamines directly into circulation instead of transmitting messages via the efferent axons. They act as a first responder to stress within seconds, and they promote fight or flight response. Have you ever heard of the little old lady who tries to lift the car off of somebody who's stuck underneath it and is successful? Well, it is due to these catecholamines that she's able to do something like that. So what happens is sympathetic cells arise from the primordial neural crust stem cells, which differentiate into sympathoblasts and pheochromoplasts. From here we have the biosynthesis of the catecholamines. These are known as dopamine, norepinephrine, and epinephrine. You may have heard of these things in other places in life. For example, epinephrine and EpiPen, that can help people in an anaphylactic shock type of situation. But anyways, those three things, dopamine, norepinephrine, and epinephrine, are synthesized by the conversion of phenylalanine substrates in a tightly regulated manner. So after the catecholamines are used, after Granny picks the car up off of somebody, we do have the degradation of catecholamines that needs to occur. There's three methods of getting rid of them, because obviously you don't want to stay in that state of panic forever. There's reuptake into the secretory vessels, there's uptake into non-neuronal cells, mostly the liver, and then just plain degradation. There's two enzymes that produce metabolites from this, and those metabolites and free catecholamines are filtered into the urine, which is where we can pick them up. You should have an amount of metanephrines and vanillin acid present in your urine, because that means this process is working effectively. So in most cases we use liquid chromatography or fluorometrics, mass spectrometry, something like that, to measure for these catecholamines. And it's usually done on a 24-hour urine. So what are some of the things that happened with this sympathetic hyperactivity? Well, it can just happen, just be an autonomic dysfunction that happens. We can have panic attacks, which is an emotional response. Sometimes people with hypoglycemia, an injury, infection, psychosis, or seizures. Can have issues. Drugs can cause this. Decongestants, appetite suppressants, stimulants, bronchodilators, MAO inhibitors, thyroid hormone, cortisol, etc. And foods containing tyramine, which include imported beer, red wine, soy sauce, overripe fermented foods, smoked or aged meats, or something called a pheochromocytoma, which is a catecholamine producing tumor. Pheochromocytomas are very interesting. It's just a tumor that secretes catecholamines on its own and causes the sense of panic attacks. So these people will have, just for no reason, all of a sudden start having these panic attacks. So what they need to do is check for the fractionated metanephrines and catecholamines for a diagnosis. They look for urine metanephrines, which is probably the most sensitive test for this, and some other things that they can do. They'll also do a CAT scan, MRI, PET scan to see if they can localize this tumor and find it to get rid of it. Usually they'll do surgery. Removal is quite high risk. Usually catecholamines fall to a normal level within 1 week of resection. And the outcome prognosis is fairly is good, but it can reoccur. A couple other things to mention: an adrenal incidentaloma is just an adrenal mass, typically about 1 centimeter in diameter, found on a CAT scan, MRI, or ultrasound in the abdomen. Autopsy results often find these in about 6% of people, and the prevalence increases with age. They should be assessed to see if they're malignant or not, or if there's a hypersecretion going on. Surgery can be considered if it's cancerous. Another thing to mention is a neuroblastoma. Some people have heard of this. It's a malignant adrenal medulla tumor that generally occurs in children. It can secrete epinephrine and norepinephrine. All right, this completes our chapter on the adrenal system.